very nice. Where we will discuss the treatment of diabetes mellitus. Okay? In this lecture, I hope you understand that we don't only discuss pharmacology, but we try to cover other aspects related to medicine, related to pathology, and most importantly, to public health. Because as you know it, diabetes is one of the major chronic diseases of our time. It is a major public health problem affecting a high percentage prevalence and incidence around the world. And it is a chronic disease, which means that the patient will suffer from this problem for long periods of time. I'm not dealing with an infection that will go away within 2 weeks or something like that. No, I'm dealing with a problem that might stay with the patient more than 30 years or something like that if they are lucky enough. And they become lucky if you work well and you do your job as a physician in a good way. Now, to start with and to highlight how important the problem is, I will give you an outline of the goals, general goals for the treatment of diabetes. And in these goals, you will notice that we're not focusing on the general symptomatic relief of these patients, but also on the long-term complications of the disease. So to start with, in any condition, we always aim to control the symptoms. This is what the patient wants. And if you understand the pathology of diabetes, you have to know that the major problem is hyperglycemia, high blood sugar in their body. Now, this is not something they will tell you, okay, I have hyperglycemia. Hyperglycemia is manifested by symptoms. These symptoms could be the simple 3 Ps, which is polyuria, polydipsia, and polyphagia. It might extend to very bad symptoms affecting the weight and also affecting the major functions of the body. This is important as an image for you as a physician in front of the patient, but what's more important are the following two, which is, first off, to prevent the acute complications of the disease. And I mean the word prevention. I don't want to hear that a diabetic patient is having an acute complication, because that means I'm not doing my job well. These complications, like the diabetic ketoacidosis and the non-ketotic hyperosmolar state, you will discuss them next week. It's important to know that these things are life-threatening. Okay, the patient might die if they have such complications. And the other important thing, it indicates that the disease is not well controlled. So the treatment you are giving is not optimal. Can you prevent them? Yes, we can prevent them if we control diabetes in a very good way. What's more inevitable, which means that we cannot prevent in 100% of situations, are the long-term complications of the disease. Unfortunately, whatever you do, patients with diabetes at some point will complain of the long-term complications. And these can be broadly divided into 2 types. The microvascular complications, like the ones affecting the eyes, retinopathy, or the kidneys, nephropathy, or the nerves, neuropathy. These are called microvascular complications of diabetes. Another important type is macrovascular complications, the ones affecting the big vessels, like the peripheral arteries, or even the vessels, the coronaries, and so on, leading to hypertension and ischemic heart diseases. Now, these things, we cannot prevent them in 100% of cases, but what we can do is slow the progression of these complications, and if they happen at one point, I can prevent the severity, the advanced stages of these complications. In general, if you do the aforementioned 3 objectives, you will end up with something very important, which is to improve the quality of life in these diabetic patients. And if you have a family member who has diabetes, you will notice that diabetes affects the quality of their life so badly. it affects even their psychological system, which means a lot of diabetic patients, due to the poor quality of life, might be depressed. وبالتالي you have to treat them intensively and comprehensively. And as I always say, the current treatment of diabetes does not depend on one person. يعني مش بس هالشخص اللي متخصص بالاندوكرينولوجي هو اللي بيعالج الدايابيتك patient. لازم يكون حاليا برا في team of support for this diabetic patient, including an endocrinologist, an ophthalmologist, a neurologist, a nephrologist, والmost important اللي هم nutritionists and the ones that the professionals that guide the types of exercise, aerobic exercise for these diabetic patients. Now, such approach, it looks like it is very hectic and might be so hard for us as physicians and for the patient and for the families and so on, for the economy in general. So the question is it worth it? وانت دائما كيف تعرف انه اذا انت بتدفع ملايين الدولارات to treat a condition? How do you know is it worth it or not? We do something called long-term clinical trials. And since I was a student and until now, we still use the same study approach to show you that the treatment, comprehensive treatment of diabetes is worth it. This study was performed in the UK and it lasted more than 10 years. What they did a professional, intensive and comprehensive treatment of diabetes and then followed the patient up to 10 years and even more. The important thing they found is that there was a significant reduction in the mortality of these patients. Is that good? Is it worth it? Of course it is worth it. We're not, the survival of these patients is improved that much. In addition to the mortality, there's something we call morbidity, which is how their lives are affected due to the concomitant diseases and so on. What they found, there is also a significant reduction in the microvascular complication. يعني البيشنتس بطل يصير عندهم انه nephropathy so advanced انه مضطرين يعملوا dialysis, which is one of the worst stages of diabetes. انه اللي عنده diabetic patient تحكي له انت عارف لو صرت عندك problems with the kidney to end up with dialysis. It's so bad. In addition to that, the percentage of patients who lost their vision due to advanced retinopathy was reduced, which is a great achievement. And also the macrovascular complications were reduced. The percentage of ischemic heart diseases, peripheral vascular diseases was reduced when patients were treated intensively and comprehensively. That's why we have to deal with diabetic patients not as subjects. Hey, خلاص أعطيه دواء ويلا روح. No, we have to follow them up. We have to have a comprehensive approach that deals with all of their problems and not simply looking at hyperglycemia as something to give a drug and that's it. Now, to understand the pharmacology, you have to always look at the natural history of diabetes. Diabetes as a disease, if you understand from your pathology, is a problem with insulin secretion in some cases, and also is a problem with the insulin peripheral activity in the majority of patients. In general, if we drew the relative insulin secretion in diabetic patients versus time, we will notice something very bad for us as physicians, which is the fact that this relative insulin secretion decreases over time. Now, to تعرفوا بأنه type 1 diabetes is a disease where there is no insulin secretion at all. So, that's fine. You have zero insulin secretion here. The problem is, and the sad thing, in diabetic patients with type 2 diabetes, when you discover them, when you diagnose them, most of the times they don't have zero insulin secretion. They have some insulin secretion. But the sad thing is that the insulin secretion will go down and down and down further across the years until it reaches the level of 0. There is no insulin secretion at all. And that's why they always tell you, you start with type 2 diabetes in one patient, but you have to know in almost 10 to 15 years, most of these patients will be converted to type 1. يعني ببطل عندهم insulin secretion at all. الآن, in general, one important thing to know in the treatment of diabetes, the comprehensive approach تبعها, does not always depend on drugs. There is a significant percentage of patients who were well controlled just by doing this, which is committing to a very balanced and good diet regimen in addition to exercise. لأن بيحكوا بأنه على الدراسات more than 10 to 15% reduction in the level of glucose was achieved just by committing to a good diet and exercise. It's not uncommon إنه يجيك patient عمره 40 سنة وعنده type 2 diabetes وما بياخدش أدوية. Why? Because they are doing fine with the diet and exercise. If you don't do that well, you have to understand that we have to move into the next stage, which is the stage that sucks, which is the drug stage. Now, we usually start with single drug therapy, but we know, as a matter of fact, that in most cases, we will end up using combination. Combination therapy is one of the saddest things in our practice of medicine. The patient لازم يكون معه شنطة زي كل المرضى الأردنيين هسه معه شنطة بياخد more than 5 to 6 drugs per day. تمام؟ This combination therapy means that the insulin secretion is going down, the peripheral insulin resistance is increasing as we speak, and then they will end up with a stage where there is no insulin secretion at all. At that point, what should we do? Simply, the most important thing and the mainstay in the treatment of diabetes, which is the use of insulin. Tamam? Notice that this insulin therapy at some point might be even combined with other drugs. It's not always on insulin alone, but could be combined with other anti-diabetic agents, as we will discuss tomorrow. And as I told you, in type 2 diabetes, we discovered the patient at this stage where there is a significant reduction of insulin secretion combined with a huge peripheral insulin resistance. At that point, we know it in 10 to 15 years maximum that they will end up with a total destruction of the beta cells, وبالتالي zero insulin production. At that point, we can consider them converted to type 1 and they need insulin treatment. While with type 1, it's more of a straightforward approach. You discover the patient on a zero level of insulin production, وبالتالي the only treatment possible for these patients will be what? Insulin injection. Since insulin is the mainstay and the most important factor, I'm going to spend the whole lecture today talking about insulin therapy, how we deal with it, what are the types of insulin, and what to expect from patients who use insulin. And tomorrow we will discuss all other anti-diabetic agents. Now, simple approach, simple start, when do we use insulin? What are the cases that you have to use insulin in? The first answer should be always what? Type 1 diabetes. Because in type 1 diabetes, there is no insulin production, or you have no other choice but to start the patient on the replacement therapy of the missing hormone, which is insulin. Now, the other thing, can we use or should we use insulin in type 2 diabetes or not? Actually, yes, and in most cases, it's coming. Whatever you do, it's coming. So in all the type 2 diabetic patients who have an uncontrolled disease, you have to use what? Insulin therapy. Not only that, if you have a diabetic patient who has type 2 diabetes and she became pregnant, you have to know that the current practice says we don't prefer to use the oral antidiabetic agents. Because actually a lot of these drugs carry some harmful effect on the fetus. And that's why we switch the patients to insulin therapy. In addition to that, Any case of acute complication of diabetes, always remember these acute complications are life-threatening. يعني بيجيني المريض على الطوارئ يا بلحق يا بلحق. هل معقول أعطيه oral antidiabetic agent? Of course not. It has to be treated with insulin injection. These could be diabetic ketoacidosis or the non-ketotic hyperosmolar complications. And finally, any diabetic patient with type 2 who undergoes a stressful situation, like for example, مريضة أو مريض diabetes type 2 ووضعه ماشي على الأورال antidiabetic agent. فجأة انكسر. لازم ندخله على العملية. لأن لازم تعرفوا بأنه بالcurrent practice نحكي للبيشنت you have to be admitted 2 to 3 days prior to the operation لحتى نعمل regulation of the blood glucose level. How do we do it? By using insulin. So in cases of surgery, in cases of trauma, injury, أو حتى systemic severe infections, we have to switch the patient from the oral antidiabetic agents into insulin therapy. طيب, كلها مقدمة. The important thing is here. Now, as a start, we don't have one type of insulin only. You have 4 major types of insulin available to you as a physician and available to the patient. Which one do you use? In general, I'm going to explain it to you in a very simple way. In any injectable drug, you always have to speak in pharmacology terminology that we care about the following 3 things. The onset of action of the injectable drug, the peak of action of that injectable drug, يعني المرحلة اللي بيكون فيها maximum efficacy. تمام? Most importantly would be what? The duration of action of this injectable drug. الآن شو التارجت تبعك بالتريتمنت اوف diabetes؟ شو الهدف الأساسي؟ إنه الهايبرغلايسيميا تنزل. الآن if I imagine إنه الهايبرغلايسيميا is my target, الآن the insulin therapy is a way of traveling to your target. The type of insulin that we have in our bodies can be considered a regular insulin, the one that looks like the endogenous type of insulin. Can be simplified or exemplified by the fact that it looks like we are traveling to our target driving a car, a good car actually. تمام؟ هناك التارجت تبعي, I'm traveling there by the car. Now, lucky you, we have another type of insulin that might take me to my target in a much faster way. It's just like traveling by airplane to my target. This is called the rapid-acting insulin. At the same time, we have other much slower ways of reaching to our targets. Like what? شو ممكن كمان إشي يوصلك للتارجت تبعك؟ بسكليت, مشروع دراجة. Then you travel to your target using a bicycle. Will it be slower or faster than traveling by the car? It's gonna be slower. But is it more enjoyable or less enjoyable? In most cases, it is more enjoyable traveling by the bicycle than by the car, as you will see in a minute. And finally, the one that is most boring, which is the slowest one, is simply the one called the long-acting insulin, and it looks like I'm traveling to my target just by walking. تمام? كل هذا بس just as an example to imagine how things work. Let's apply that in pharmacological concepts and terms. To start with, لازم تعرف إنه this regular insulin is the reference point. يعني أنا أي شيء بقارنه ب regular insulin because it looks like the endogenous type. This regular insulin, if we look at it according to that figure I showed you previously, it works like this. The first thing to notice بأنه onset of action is not immediate. يعني أنا مش مجرد ما ركبت بالسيارة على طول راح أوصل على التارجت تبعي. It takes at least 30 minutes to start having an effect of such a drug. So the onset is not immediate. At the same time, the peak of action takes even longer time to reach, ولكنها not sustained. So it takes about 2 hours to get to my peak action of the drug. And finally, the duration of action is very long. It reaches up to 8 to 10 hours of action. تمام؟ لا. This is the regular patterns. يعني الانسولين اللي in your bodies in normal subjects works like this. Now this insulin is available to you as something called the crystalline zinc insulin. لازم تكونوا عارفين لأنه رح تستخدموه اللي هسه بروح الطوارئ لازم تعرف هذا الاسم. This is usually given by subcutaneous injection, but it could be given IV in emergency, and it's actually our preferred option in emergency situations to use this regular type of insulin. تمام؟ لا. This is the regular scenario. But what about the rapid acting, in which we travel to our target using a much more advanced and fancy way, which is the airplane? Look how it works. The striking difference would be what? The onset is almost immediate. يعني بمجرد ما أنت تعطي injection to the patient, there will be a start. You start the process of reducing the blood glucose level. And in addition to that, its peak is so high. يعني أنت you achieve a very high efficacy بمجرد ما أنت تعطي الانجكشن in comparison with the regular. الآن طب إيش disadvantage will be? Duration. In the regular one, we have a duration of action reaching up to 10 hours, while in this we only serve for 4 hours. شو الديفرنس؟ بدنا ديفرنس على أرض الواقع، بديش حكي. ديفرنس لو إنه إجا شو اسمك؟ عمر. والله يبعدك عن الدايابيتس، هسه جبت له صحن كنافة. نعم. وعنده الريجولار تايب اوف انسولين وعنده الرابيد تايب اوف. طبعا صحن كنافة بده انسولين ولا لا؟ أكيد يعني ما فيش مجال. تمام؟ لا، أنت الفيزيشن تبعه. بدك تعطيه رابيد ولا بدك تعطيه ريجولار؟ What is the difference؟ شو بتفرق معه؟ لو أعطيته رابيد شو لازم تحكي له؟ Exactly. إذا the first thing إنه when to take the injection. If you have the rapid, then you can take it immediately before you eat. وحتى بيحكوا بإنه even if you started eating, تمام? And you forgot to take your injection, you can still take the injection during the meal. Why? Because it has an immediate onset of action, and don't forget إنه شوفوا قديش البيك تبعته very high, and we reach it right away. طب إذا بتعطيه regular insulin شو لازم أسوي؟ بدي at least 15 to 30 minutes to wait until it gets the onset of action. بتبطل تظبط بعد ربع ساعة. تمام؟ But this is one major difference. طيب. If we compare between them according to the duration of action. إذا المريض بده ياخذ rapid acting insulin طول اليوم. كم مرة لازم نستخدمه؟ More than 4 times actually. Because the maximum تبعها 4 to 6 hours. وبالتالي it has to be repeated every 4 to 6 hours, which is bad on the patient. While for the regular, it is enough to take it twice, and it's going to cover most of the time during the day. This is for the regular and rapid. Now notice, this rapid-acting insulin is actually given simply just like the regular insulin, could be given subcutaneously and could be given IV in emergency state. لأن لو سألتكم تشيروا أنا بالإمرجنسي أستخدم الرابد ولا أستخدم الريجولار؟ Which one do you prefer? ليش تتخوف؟ لا أكيد الرابد. هذا immediate onset of action والبيك تبعته بآخر الدنيا. بس هون أنا شو كاتب لكم بإنه less prefer. Why? Because يا شباب in these emergency situations with diabetes, we don't prefer to reduce the level of glucose so suddenly, so rapidly. We want to reduce the level of glucose gradually and progressively. And that's why we don't prefer to use rapid, we actually prefer to use regular insulin. تمام؟ And you will see it when you discuss the treatment of diabetic ketoacidosis. لأنه الانسولين action on the glucose affect the whole metabolic state. فأنت if you reduce the level of glucose all of a sudden راح تخرب الدنيا بالنسبة للmetabolism of the proteins and fats and so on. وبالتالي it could complicate the state in the brain and so on. تمام. So we prefer to reduce the level of glucose gradually rather than sudden. طيب هذا كله حكي emergency states وصح نحن في نعم. But what about the regular day? Regular day requirements. The regular day requirements, you have this type of insulin, which is the intermediate acting insulin. Its action looks simply like this. What are the differences in comparison with the regular one? First off, the onset. The onset is even slower than the regular one. يعني الريجولار one كان بدنا ربع ساعة لنبلش يشتغل. In this intermediate action, we might need even more than 1 hour to start the onset of action of this drug. Duration تبعه would be what? Much longer. It might reach up to 18 hours. So once daily injection could be enough to cover the patient's needs. But what's the most important advantage of this drug? Peak? شو معنى هالبيك؟ الآن أنا حكيت لكم لما نحكي peak action شو يعني؟ The most effective action of the drug. يعني the best way to get the efficacy of the drug is to reach the peak. As can be shown here, this peak looks nice, prolonged, and stable. Any drug that has a very important and nice plateau of action is a good injectable drug. And that's why this drug could be considered one of the most convenient drugs to use. Because the peak is so stable and prolonged. It might reach up to 4 to 6 hours وهو بس بالpeak. يعني شو ما بتعطيه glucose, it is achieving very high efficacy during the peak times. تمام? That's why it is a preferred option. طب ليش الريجولار يعني بصير له absorption سريع والانست تبعه سريع بينما هذا takes time وبصير longer duration action؟ شو بتتوقعوا بصير؟ It actually depends on the chemistry of the drug. هم شو سووا؟ هذا الدرج اجوا ربطوه ب one chemical وبالتالي this chemical will form less soluble complexes لما تعمل injection subcutaneously. تمام؟ والabsorption بصير slow. And that's why it has a prolonged duration of action. تمام؟ It is related to the way they manufacture the drug. الآن this drug, most important thing, يعني لازم تكون عارف بأنه this is only given as a subcutaneous injection. It cannot be given IV injection. وزي ما يعني المفروض إنه برضه هاي تفهمها مباشرة. إذا كان the onset of it needs more than 1 hour, so what's the point of giving it as an IV injection? There's no need. And that's why this drug has to be given by subcutaneous rather than IV injection. طيب هذا كلياته using the bicycle. طب what about walking to your target? Getting to the target of reduction in the glucose level just by walking. What do you expect? Something very boring. It looks exactly like this. The only advantage of this drug would be what? Duration of action. It can cover the patient more than 24 hours. يعني ممكن to be extended up to 36 hours. يعني خلص ياخذ الانجكشن and that's it. But what are the problems with this drug? Onset is so slow. فاللي بده ياكل صحن كنافه it doesn't work. إلا إذا بدك تاخذ الجرعة بالليل والصبح بدك تاكل كنافه. تمام؟ onset is so slow. In addition to that, does it have a peak? It actually doesn't have a peak. وبالتالي do we reach a good maximum efficacy of the injection? No. The only single important advantage of the drug is the very long duration of action. تمام? But is it used? It is used. Actually, هسه حورجيكم. And it is one of the most expensive actually types of insulin, as you will see in a minute. In general, this is given only by subcutaneous injections, and this drug has an isoelectric point, and it is important to tell the patient that you can never mix this drug with any other injectable drug in the same syringe. Why? Because you play with the isoelectric point of the drug, وبالتالي it loses its pharmacokinetic and pharmacodynamic property. كله حكي you won't appreciate until you put all these drugs on top of each other. هاي اللي لازم المنتال image تبقى براسك. الريجولار type of insulin هو our reference point. تمام؟ The onset of it is not that rapid but not that slow. It actually takes about 15 minutes. Duration of action is fair enough up to 8 hours. The major difference عن rapid type of insulin إنه this has the largest peak and it is an immediate onset of action. So the patient can take the drug at the time of the meal, right away. And the other thing to know is this intermediate acting has a very nice plateau, stable, and prolonged peak of action. So it is the most convenient way of giving insulin. And finally, this long acting is boring. Boring, as it does not have a peak. تمام؟ وبالتالي it does not help me with the meal. كل هالأربع أنواع. طب okay, how do I treat a diabetic patient? How to use these drugs? الآن, the most important concept بكل treatment of endocrine problems إنك تفهم بأنه إحنا we have a missing hormone and we want to replace it. What is the best way to replace a missing hormone? It's something we call the simulation of the normal secretion pattern. يعني احنا بدناش نعيد اختراع العجلة. We have to simulate. يعني تقلد what the normal body, the normal subject does with the secretion of this hormone. تمام؟ الآن, from your physiology lectures, you should know that if we look at the insulin secretion per day in the normal subject, we will see that it looks like this. أول استنتاج لازم تعرفوا شو هو. Exactly. We never get to a zero insulin secretion at any point. يعني هلا أنت لو أخذت من كلكم كnormal subject blood samples and I measure the level of insulin, can I find any subject with a zero level of insulin? No. It should have a basal level of insulin secretion. وانت صاحي وانت نايم وانت بتاكل وانت بتاكلش لازم يكون في عندك basal level of insulin secretion. تمام؟ At the same time, we have at least in any normal subject, طبعا بالnormal subject, 3 peaks. شو هدول ال 3 peaks؟ شو؟ اللي هم الميل induced surges. يعني بتفطر تتغدى تتعشى كل مرة بصير في absorption of the food converting into glucose. You should have a surge and a peak of insulin secretion. Again, this is the normal subject. اللي بياكل على الطالع والنازل اللي الشوكولات هاي they do not miss at all. You will have even more and more peaks of insulin secretion. احنا شو دورنا? Is to simulate this. We have to give a picture that looks exactly like what the normal body and the normal subject produces. Question is for you. How do you meet the basal needs of insulin? كيف ممكن أقلد الجسم بالإنسولين basal insulin secretion? شو أعطيه? What type of insulin? Then the most important one in such cases is the long-acting insulin. تمام؟ لأنه it doesn't have a peak, it covers me for almost 24 hours and even beyond that. وبالتالي إنه it meets my basal needs of insulin secretion. What about the intermediate acting? It also serves the basal needs of insulin. لأنه تذكروا إنه the peak was so prolonged it could extend for more than 6 hours. وبالتالي it meets the basal needs. بس وين تيجي المشكلة؟ تيجي المشكلة مع الميلز وبتيجي المشكلة مع unexpected sugar intake. In such cases, what should we do? We have to use the rapid or the regular acting insulin. تمام؟ لا. How do you put that into one full picture, one image? In general, the thing that makes more sense is something like this. For any diabetic patient, I give them one injection of the long-acting insulin, for example, at bedtime. It will cover them for how long? 24 hours. ولما بدي ياكل breakfast, lunch, supper, or dinner, I should give them another type of insulin, which is the rapid-acting or irregular-acting insulin, which comes up to 4 injections per day. تمام? This is with the rapid-acting and the long-acting. Notice there is another type of regimen. ممكن إنك تعطي intermediate once per day اللي هي bedtime. At the time of the meals, major meals, you give the regular type of insulin 3 times per day. Again, 4 injections per day. Finally, you could give the intermediate acting 2 times. يعني احنا حكينا الانترميديت up to 18 hours. بضل عندك 6 hours not covered. فبتعطيهم twice in addition to 3 times of the rapid acting insulin. كم مرة بده يعمل injection؟ 5 times. كلهم هذول يعتبروا شو؟ باد. في حدا بيستحمل يعيش 30 سنة وهو بياخذ 5 إلى 6 injections per day? Doesn't work. لا, unfortunately, this is a treatment for life. صح؟ متى ما بلشت الانسولين, that's what you have. They produce something which are called the pre-mixed preparations to deal with this problem of compliance and to improve the quality of life of diabetic patients. In such cases, جابوا 1 ampule وعملوا mixture of 2 drugs اللي هم, for example, regular acting and the intermediate acting. لما تعمل هذا المixture in 1 syringe, what you can do is give 2 injections per day. 1 at the time of breakfast and 1 at the late evening time. تمام? At the supper time. تمام? الآن, how does it cover you? It covers you with the intermediate action for the basal needs of insulin, and it covers the meal-induced surges with 2 injections of the regular insulin. الآن, this was produced in 70-30 or 50-50 percentages. تمام? الآن, they are trying to improve it. They are using a rapid rather than a regular type of insulin. The most important thing is that we calculate how much the patient needs per day, and we split the dose into 2 doses, 2/3 given in the morning and 1/3 given in the evening. ليش تتوقعوا؟ ليش بنركز إنه الصبح نعطيه أعلى دوز وبعدين بالليل بنخفف دوز؟ Yeah, making sense. But 2 important things to know. إحنا diabetic patients, a lot of them have something called fasting hyperglycemia. يعني هذا بيصحى الصبح وبيلاقي البلاد شوجر تبعه 300 and above. تمام؟ فإحنا we want to give the highest dose in the morning. والother thing إنه which is weird يعني إنه صح عنده fasting hyperglycemia, but a lot of diabetic patients ممكن يكون عندهم nighttime hypoglycemia. وبالتالي we try to reduce the dose in the evening and increase the dose in the morning. نعم, زمان كانت التريتمنت الدايابيتس تيجي بتعطي للمريض هاي السيرنجز هذول very small زي ما تشوفوهم, تعطيهم امبيول, تحكي له بدي اياك 10 يونتس, بيجي بمسك الامبيول وبسحب ال 10 يونتس هذول. طبعا زي ما انتم شايفين هاي صحي صغير هون وعلى ارض الواقع برضه صغير. You cannot see. فبالتالي it was يعني a harassment for the patient. Don't forget إنه في good percentage of the patients who are illiterate, for example. تمام؟ وبالتالي it was hard for them to deal with the syringe and ampule. And one of the greatest things introduced into market was the insulin pen. زي ما انتم شايفين هون. هذا الانسولين pen يحتوي على insulin cartridge inside. بس most importantly زي ما انتم شايفين هون في window. هاي الويندو انت بتلف بالقلم, تمام, you scroll up and down لحتى you reach الليفل اللي بدك اياه. بدي 10 units 11 units and so on. تمام؟ لأن ال important thing إنه this is also can be carried by the patient in their pockets. هدول الأمبيولز كانوا يضطروا لازم يضلوا بالثلاجة لحتى ما يخربش الدواء. This one is thermostatic وبالتالي إنه thermostable sorry وبالتالي إنه you can carry it all the time. فلما بياكل كناف he can just take it out of his pocket and use it. One thing that was like a big invention but it faded away, it died away اللي هي الانسولين pumps. هذول الانسولين pumps كان الأساس إنه أنت بتجيب electronic pump وإلها توصيلات. You insert these connections inside the skin subcutaneously وبتخلي هاي البامب outside. The interesting thing about this digital electronic pump إنه it reads the glucose level وبتطلع لك إياه هون. و this pump is programmed. إذا طلع الليفل 200 أعطي هالقد dose of insulin and so on. فكانت لما طلعت إنه this is a great achievement خلص إنه بنبطل إحنا نضلنا نراجع مرضى الديابيتس نشوف إنه زبطت أمورهم ولا لا. It reads and it gives the dose accordingly. But it faded away. أول شيء إنه it's very expensive. مش كل السنترز they can do it or they want to do it. This insulin cartridge it has to be replaced every now and then. هاي بطارية متى ما خلصت تخرب السيستم بدك ترد تبدلها مرة ثانية لأن الكونكشنز هذول اللي بتحطهم under the skin they are susceptible to infection. It's not making that great utility currently. Now, two final notes before we leave. The first one is that the subcutaneous injections are given in 4 areas in the body. I'm not going to teach you how to give an injection, but it's important to me to know that these different areas differ according to the rate of absorption. For example, if you want a fast absorption, you advise the patient to take the injection in the abdomen. While if you want a much slower absorption of the drug, they have to take it in their buttocks. Tamam? This is okay. The important thing is that you have to tell the patient, never use the same place of injection repeatedly. يعني ما تضلش مركز على نفس المكان كل يوم. تعطي بالأبدومن نفس المنطقة. Why? I will show you why in a minute. Pharmacology means side effects. What is the most important side effect of insulin? Actually, it doesn't have any other side effects. It's hypoglycemia. Hypoglycemia is not something the patient can come and tell me, well, I have hypoglycemia. They come and tell me what? Symptoms. Well, hypoglycemia is actually reflected in the body by symptoms. What do you expect these symptoms are? Look at these side effects. في headache or anxiety, most importantly tachycardia and confusion, في vertigo and sweating, diaphoresis. بتذكركم بشيء؟ ها؟ هايبر اللي هو ايش هذا الهايبر منين في جاي السمبل؟ Exactly. These are the sympathetic overactivation symptoms. لأنه احنا عارفين إذا نزل الجلوكوز ليفل مباشرة there is an oversympathetic activity. الآن مباشرة بمجرد ما البيشنتس بلشوا يشعروا بالسيمبتومز هاي is it a risky thing to have hypoglycemia؟ ولا عادي يعني شو يعني؟ طب مين ريسكي إنه يكون عنده hypoglycemia ولا hyperglycemia؟ هايبو خلص يعني متأكدين تمام؟ إذا the most important thing إنه حتى هسه روحوا اقروا بالguidelines of the treatment. They care so much about the hypoglycemia أكثر من hyperglycemia والguidelines of treating hypoglycemia. مشكلتك لما تعطي للpatient insulin, it is a must إنه they will suffer from hypoglycemia. وين مشكلتنا بالhypoglycemia؟ إنه it could reach levels that are incompatible with life. يعني إذا نزلت below 30 أو even 20 الجلوكوز levels اتأكد إنه المريض راح يدخل بكوما and if you don't catch them at a good time point they will die. تمام. عشان هيك دائما بعلموكم انه اذا شفت كوماتوز بيشنت وانت مش عارف هو هايبو ولا هايبرغليسيميا تعطيه جلوكوز ولا لا؟ ولا تعطيه انسولين؟ تعطي جلوكوز rather than give insulin. And one of the things important لازم تحكيها للبيشنت انه you have to educate them انه هاي السيمبتومز اذا صارت شو لازم تساوي؟ شو لازم تساوي؟ هذا المريض اللي صارت معه هاي السيمبتومز كل ايش؟ مش كنافه حبة شوكولاتة it's good. تمام؟ فبالتالي you have to tell them. بس وين المشكلة؟ شو بتوقعوا في مشكلة ممكن تصير؟ شو بصير بقى؟ ها؟ Exactly. إذا these symptoms are a reflection of sympathetic overactivation. مشكلتنا بإنه 3/4 المرضى تبعون الدايابيتس عندهم هايبرتنشن. بمعنى آخر زي ما إذا بتتذكروا من السنة الماضية one of the treatments of hypertension هي البيتا بلوكر. إذا بتعطي البيتا بلوكر لواحد بياخد انسولين اتوقع بإنه they will not feel the symptom. يعني هو بيكون نزل عنده الليفل اوف جلوكوز less than 40 ملغ per deciliter واللي هو مش داير. بالعادة اللي ما بياخدش بيتا بلوكر أول ما ينزل الليفل اوف جلوكوز بلش يشعر بارستيزيا بليرنج اوف فيجن حاس حاله داير بيجي بيقول لك اوكي انا او بلش يعرف كمان بيقول لك اوكي انا اي نيد تو تيك شوجر. هذول اللي بياخذوا بيتا بلوكر شو بصير؟ لا بيعرفوا ولا بصير عندهم تاكيكارديا ولا بصير عندهم تريمور كلياتها مش موجوده. فthis is something we call masking of symptoms. You have to tell the patient about this and you have to try to replace the beta blocker أو على الأقل to reduce the dose of beta blocker. زمان كانوا patients يصير في عندهم هيك إذا أخذوا injections like dystrophy, atrophy and dystrophy. تلاقي هالبيشنت أخذ الانسولين بعد 6-7 أشهر ولا الأبدومين تبعه الفاي تبعته إما صار فيها تجويف هائل أو إنه صار في عنده big lumps. بطل يكلم بس برضه عينين. تمام؟ يعني فوق ما هو diabetes وديبريشن وقرف بعدين يصير عندهم. Currently we don't have. Why? زمان كانت هسه. إذا exactly the source of insulin that was previously in the market came from animals. كل المرضى كان يصير عندهم allergic reaction وكان يصير عندهم atrophy أو dystrophy. حاليا الانسولين is produced by recombinant DNA technology والallergic reaction is not there anymore. عشان هيك احنا حكينا بأنه patient should not use injection at the same time in the same place. One important thing to know بأنه it could lead to something called erratic absorption. Why? هذا المريض اللي بضل ياخذ الانجكشن في الابدومين في منطقة معينة. أول شيء ممكن يصير بأنه يصير عندهم سكار تيشو. السكار تيشو هو عبارة عن وتر فايبروز. أنا بدي أعطي الانجكشن وين أصلاً؟ السبكوتينيوس تيشو. مش أعطيها الفايبرس تيشو. الفايبرس تيشو بصير فيها. عشان هيك بتلاحظ إنه هذول المرضى sometimes الابسوربشن تبعهم بيرفكت على 100% sometimes الابسوربشن تبعهم does not happen at all. called erratic absorption. عشان هيك it's a must إنه كل المرضى اللي بياخذوا injections repeated don't repeat it at the same place all the time. You have to rotate these injections. Now, tomorrow's lecture we're going to discuss the oral antidiabetic agents and you will see that these drugs we're going to discuss tomorrow are drugs that will target the following: the intestine, the pancreas, the muscle, the liver, the adipose tissue, the kidneys, in addition also to the brain. Be prepared because you have an interesting day tomorrow.